Welcome to Ageless and Outrageous, your favorite podcast about how to age amazingly. I'm urogynecologist and hormone and sexual health expert, Dr. Kristen Jackson. Every week, my incredible and knowledgeable nurse practitioner, Rosalind Arp, and I share our combined 30 years experience to guide both men and women as they age. Listen as we dive into a variety of topics, including hormone optimization, pelvic floor health, maintaining a vibrant sex life, weight gain issues, and skin, hair, and body changes as we age. These real-life insights are always rooted in solid scientific knowledge. Tune in for a dose of laughter, knowledge, and an honest perspective on the incredible adventure of growing older. Welcome back to the podcast, where today's topic is how to remove all the obstacles in your life to having an amazing orgasm. We have so many patients coming to us with orgasm challenges from a variety of different ways. Sometimes women struggle to reach orgasm. Sometimes they can reach orgasm, but the orgasm itself is just kind of blah and not as exciting as it once was. Some women have never had an orgasm. Some women feel they can only have orgasm with one specific type of stimulation, and they want to be able to have an orgasm with more types of stimulation. So we love getting into this with our patients and really figuring out what are the barriers to having an amazing orgasm and how can we help you get there.
In addition, many women think that not having penetration orgasm is abnormal, but a lot of women actually don't. So we are going to talk about multiple different reasons or ways to have an orgasm for women. But when I talk about patients regarding their sexual satisfaction or maximizing their sexual satisfaction, I have an analogy regarding a waterfall.
If you think about a waterfall, when the water is flowing over the falls with no barriers, it's going to reach the pond below. You can think about that pond below as the best maximal sexual satisfaction. Mm-hmm. But if we get a boulder at the top of the waterfall, the flow is going to be slightly decreased. If we get 2 or 3 boulders at the top of the waterfall, the flow is going to be significantly decreased. So I want to find out what boulders are blocking your path to sexual satisfaction and remove them.
But sometimes there are some boulders that can affect the flow of the water coming down. And depending on what boulder you have is on what treatment we recommend for you. So the biggest boulder that usually is at the top is pain and atrophy. So if you have that boulder, no matter how much other little boulders I remove from the bottom, you're not going to have great sexual satisfaction. Pain and atrophy always comes at the top. And then some of the other smaller boulders are low hormone or low libido or no desire to have sex. And then also lacking of orgasm or not so great orgasm. So those are the other boulders that can be at the bottom. But the first typical one is the pain and atrophy.
So pain during sex or atrophy is unfortunately more common than we would like it to be. And healthy sex should never be painful. I always recommend, even if you think sex feels very comfortable, that the use of a good lubricant is always a good idea because it enhances sensitivity and enhances the sensation during intercourse. But definitely after menopause, at minimum, a quality lubricant is absolutely necessary because most menopausal women, if they're not replacing their hormones, are going to have a vagina that's a little bit drier, a little less stretchy, a little more painful, and at least lubricating during intercourse is one important step.
And the typical lubrication I recommend is silicone-based lubrication because water-based lubrication just gets reabsorbed into the tissue much too quickly. It's good for a pelvic exam, but not so much for intercourse because it dries up quite fast. We have a product in our office called Uberlube, which is a silicone-based product that doesn't clump up or doesn't have any of those strong fragrances or irritants. So it is well tolerated by many of our patients.
It's our absolute favorite sexual lubricant for sure. It feels like silk going on your skin. It's just so silky. A little bit goes a long way. And it is so easy to use for men, for women, if you're by yourself. I think everyone should have Uberlube at their bedside table for great sexual satisfaction. But lubricants in general sit on the top of the vaginal surface and decrease the friction. They're not changing the layers of the vagina underneath. So if you are having atrophy, which is dry, tight tissue after menopause, you really need to be treating that with vaginal estrogen cream or some form of a vaginal estrogen product. Estrogen is actually going to increase blood flow to the vagina and change the cellular layers, making it more stretchy and more comfortable. What I usually describe to patients is think about a brand new rubber band. You could stretch it out and it springs right back. But as that rubber band gets dried out and older, when you stretch it, you can actually see little cracks and breaks in it. And that's what's happening to the vaginal lining after menopause. But estrogen restores our vagina back to that nice stretchy version we once had.
Yeah, and I know we have another podcast for atrophy, and there are many, many other treatments as well, more extensive treatments that we can do with it as well. But if you are having pain with intercourse, atrophy is just one of the possibilities that can occur. I think a great pelvic exam to pinpoint exactly where that pain is coming from can help your provider figure out what's the best treatment option. Sometimes it can also be a muscle issue, like hypertonic muscles of the pelvic floor, where you can have a spasm in your muscles, in your pelvic floor muscles, that can cause pain during intercourse.
And I think that high tone pelvic floor is very under-recognized in the general population. Most people have never heard of it, but the pelvic floor is a pretty amazing shelf of muscles. It's constantly changing. It has a little tension in it, so it holds up our bladder, our vagina, and our rectum. But if we jump or cough or laugh, it tightens up even more so we don't leak. And when we want to empty our bladder or move our bowels, it relaxes even more to let those things pass. And during intercourse, the pelvic floor should also relax somewhat. But a high tone pelvic floor is when that muscle shelf is constantly tense and it can't relax properly. And that often leads to penetration problems. So we'll hear patients tell us either it hurts to penetrate, or my partner can get partway in and then he hits a wall. There's no wall in the middle of the vagina. He's hitting a really tight gripped muscle. He can't dilate it. He can't push it open. Treatment for high tone pelvic floor might be working with a pelvic floor therapist to try to release that muscle. Sometimes they use some energy devices to kind of release the spasm in that muscle. And there are even some compounded medications that you can place in the vagina to help those high tone muscles relax more.
Yes, there's also vaginal dilators that can help relax those muscles as well, that the therapist can show you. And then there's also devices that you can use, like the wand, that can help relieve those tension as well. Another treatment that's off-label use is vaginal Botox to help relax those muscles.
Right. Botox is a great product for relaxing muscles wherever we inject it. So when we inject Botox into the face, we're relaxing the muscles that make wrinkles and lines on our face. Well, when we have a high tone pelvic floor, we can inject the Botox into those muscles and get a good, strong relaxation of those muscles.
Speaking of the vaginal medications you mentioned, Dr. Jackson, there's another condition that can be associated with pain, and that's a term that we call vulvodynia. And a lot of the times the medications that we use for pelvic floor spasms, we've also used for vulvodynia patients, which helps decrease the nerve sensitivity from that.
Correct. Vulvodynia is just this term of vaginal pain without an anatomic origin, meaning you don't have an infection, you don't have a cancer, you don't have something like that. But we think it's where the nerve endings in the vagina are hypersensitive. They're firing and telling your brain that there's pain there, even when they shouldn't be. So a lot of those meds you're mentioning help to dial down those pain nerves so they're not firing so much.
During a pelvic exam, one of the other things that we examine is if the pain is deeper in the vagina. And I usually my patients will say, I'm like, do you have pain right before he penetrates, or is it much deeper or positional? And that can be for multiple reasons as well.
Exactly. That's such an important distinction. Most of the things we've been talking about so far, like atrophy, high tone pelvic floor, vulvodynia, they tend to cause pain right as the penis is inserted. But if the pain is more with deep penetration, now we're looking for things like endometriosis in the pelvic cavity, or maybe fibroids on the uterus. So as the penis is pushing into the back of the vagina, there should naturally be some rocking back and forth of the uterus that happens. And that should be either pain-free or pleasurable. But if the uterus is abnormal with fibroids, or if there's inflammation in the pelvis from scar tissue, from endometriosis, from things like that, moving that uterus back and forth is going to be very painful. Many women figure this out on their own, and they'll just adjust the position so that he can't get quite so deep into the vagina, so he's not pushing on those painful areas. But if you have deep penetration intercourse pain, your gynecologist should be running an evaluation for some of those conditions.
And one of the more common things that I actually have pointed out to some of my patients and have relieved that deep penetration pain is if they have a history of constipation. When they're more constipated, they're more likely to have pain during deep penetration because there's a lot of nerves around that bowels, and that can hurt during intercourse as well.
Absolutely. I'm constantly showing our patients the pelvic model, and you'd be surprised how close together the bladder, the vagina, and the rectum really are. And there's only so much physical space there. So if the bowels are all filled up with stool, especially if it's very hard, constipated stool, it's not going to feel comfortable adding another dilator into the vagina like a penis to push on that hard stool. So having your bladder emptied, having your bowels emptied before sex just generally improves how you feel.
Yeah. So the second boulder that we usually see for patients that can affect their sexual satisfaction is decreased libido or hormones. And this is usually patients who come in, they're like, I don't have any pain when I'm having sex. I'm just not interested. That's easily treated as well for most women. And this is usually connected to low testosterone levels.
And we have a lot of podcasts on this as well, but testosterone decrease in women tends to start in their 30s. It's a slow and steady decline from there on out. So even women in their mid 30s, early 40s who might be feeling, sex is fine. I'd rather sleep than have sex. I just don't have a lot of energy to initiate. It may not totally be from the typical factors that they blame it on, like I'm busy at work and the kids kept me up and I'm stressed out. Those factors definitely can negatively affect your libido, but also contributing is lowering levels of testosterone.
So typically we treat this with testosterone replacement therapy for patients. There are two other medications that are currently in the market for also increasing libido for women. And these are only approved for premenopausal women, which is quite interesting that was the first approval because it's more prevalent in older women. But the two medications are Adi and Vyleesi.
And Adi is something that is used on a daily basis to try to increase the overall arousal, whereas Vyleesi is actually an injector pen that you can use 20 to 30 minutes before the active intercourse to kind of give you a boost of those positive neurotransmitters that increase your libido and make you more receptive to intercourse. So Adi is a daily pill to increase those neurotransmitters on a day-to-day basis, whereas the Vyleesi gives you a little boost of those positive neurotransmitters exactly when you need them.
So the mechanism of them is in your brain, like Dr. Jackson said, regarding the neurotransmitters. So the biggest side effect that actually most patients have is nausea with it. And will say that a lot of our patients do get that. So I usually start with testosterone replacement therapy first and add that in if as needed.
That makes sense because testosterone replacement therapy also has a whole host of improvements that patients see, both in the short term and things like energy and improvement in fatigue, improvement in brain fog, improvement in how we sleep, as well as improving our health long term, like protecting our heart and protecting our bones and our brain. So we definitely get the bigger bang for your buck with testosterone replacement therapy, whereas things like Adi and Vyleesi are more specific. They are specifically just to treat sexual dysfunction. And you mentioned that they were only approved for premenopausal women. I will tell you that we do offer them to postmenopausal women, but that would just be an off-label use. So very often we do use medications outside their labeling restrictions, but for Vyleesi and Adi, it's at least important to know that they are only FDA approved for premenopausal women.
And with that being said, it doesn't get covered for postmenopausal women.
That does make it more challenging for sure.
Mm-hmm.
And a unique category of women, all women, as we age slowly, our testosterone decreases. But if you happen to be a woman who has both of her ovaries removed for whatever reason, they may need to be removed, just realize that at that time, you are going to have a very sudden drop in your testosterone as well as in your estrogen from losing your ovaries. So you may have a more drastic experience with your testosterone loss symptoms as compared to a woman who's just going through natural aging.
There are also certain drugs that women can take that decreases their libido in general, and that includes birth control pills, antidepressants, and antihypertensive medications as well. So sometimes looking into those medications that you're currently taking can also help improve your libido if we change it to a different type.
And then the final thing, once we've removed all the pain that you have during intercourse and we've improved your libido, is to make sure that you have the best orgasm that you can have. And there are lots of ways to do this. Again, we spend a lot of time on our podcast talking about how to enhance orgasm, but there are many things that we can focus on. And it really depends on where you feel your orgasm is lacking. So if you're able to reach orgasm, but you just feel like the strength of that orgasm isn't as great as it once was, we really need to be talking about strengthening your pelvic floor. Because most of the pleasurable contractions that you have during an orgasm come from the pelvic floor contracting. So the healthier we make the pelvic floor, the stronger and more intense an orgasm can be. And the most effective way to strengthen the pelvic floor is with electromagnetic stimulation.
So just like we were talking about earlier about hypertonic pelvic floor muscles, this is kind of the opposite, which is the hypotonic pelvic floor muscles, where there is weakening of the muscles in the pelvic floor. And this is actually more common than the hypertonic part. As we age, we don't work out our pelvic floor muscles as we do, so it becomes more atrophied, and the muscles are not as strong. So if you build that muscle strength, there's more blood flow to the area, and it allows more better contraction when you're having sex, and also better blood flow to the clitoris as well. The best treatment, like Dr. Jackson said earlier, is the electromagnetic therapy. And we have one in our office called the Emsella chair. This maximizes pelvic floor contractions by doing an equivalent of 11,000 Kegels in a 30-minute session. So it causes hypertrophy of the muscles of the pelvic floor. So when you're trying to do Kegels on your own, you can typically stimulate around 30% of your pelvic floor muscles. But if you sit on the Emsella chair, you usually can stimulate up to 95% of those muscles.
Emsella is a great option if patients reach orgasm easily, but then the final result isn't that great. But what about if your problem is actually reaching orgasm? You feel like even if you have direct clitoral stimulation, it just takes forever. It's really difficult for you to reach orgasm. That's where we may need to improve blood flow and nerve stimulation directly at the clitoris and in the clitoral arms. And a great way to do this is with platelet-rich plasma.
So PRP can also be injected in the anterior vaginal wall where the G spot is. And these are the women that typically have had a penetration orgasms in the past, and that has weakened as well. So if you inject in the G spot, that can help with their orgasms. But one of the main questions I ask patients is if they're complaining of no orgasms, I always ask them, have you ever had penetration intercourse before? Did this just start more recently, or is this something that you've never been able to reach? Because there are some studies that show that the large percentage of women do not have penetration orgasm. So one of the main questions I ask patients when they say that they cannot reach orgasm with penetration is that have they been able to do it in the past, or was that something that they were never able to achieve? Because some women just don't have the correct anatomy to have an orgasm during penetration. There was a study that was done where women were found to have a clitoris that were 2 centimeters away from the urethra are the women who tends to have a penetration orgasm, versus women that had a further away clitoris from the urethra tends to not have an orgasm during penetration. And that kind of relates to just being stimulated while they're having sex.
Right. I tell my patients it's just a geometry problem. I mean, if you stimulated your male partner on his knee over and over and over again, he's not going to reach orgasm. You're simply not stimulating in the right spot. So for women, they can have vaginal penetration over and over again. But if that vaginal penetration does not lead to some form of clitoral stimulation, it's just not going to bring them to orgasm. It doesn't mean you shouldn't have it. It can still feel intimate and close and good. It just may not bring them to orgasm.
And that's usually when I recommend to my patients to actually use some sex toys that can stimulate their clitoris while they're having orgasms. There are some penis rings that have clitoral stimulators attached to them, or you can try to have a clitoral orgasm before penetration, which can increase the blood flow into the clitoris and can be stimulated as well. So there's multiple ways in improving it. And then also finding positions that can increase your stimulation of your clitoris. Like women, usually when they go on top, they're able to find the right position to be able to stimulate their clitoris while they're having sex.
Exactly. But all of those areas of either clitoral stimulation or vaginal stimulation, whatever it may be, can be enhanced using PRP injections. So PRP injections are so easy to do because we draw your own blood. We spin it down to concentrate the layer of platelets. Platelets are what contain all of the growth factors in our blood. And then we re-inject those platelets into an area where we want to enhance blood flow and enhance nerve stimulation. So for women struggling reaching orgasm, we inject them into and around the clitoris, around the opening of the vagina, and also, as you mentioned before, into the anterior vaginal wall where that G spot is. That's covering all the areas where we want to increase stimulation. You should know that if you're going to do some PRP injections for orgasmic support, it's not an instant result. Most patients, when we do the first injection, will have a little bit of stimulation because they've had very poor nerve stimulation there leading up to it. So when we create any increase, they're going to feel a little easier to orgasm. But we usually recommend a series of 3 injections over 3 months. And then it may even take an additional 3 months after that to continue building new blood flow and nerve supply to the clitoral region. So it's not a quick fix to the problem, but it is, within about 6 months, a relatively short answer to enhancing clitoral sensitivity.
And another complaint that we hear is patients feeling like they don't have the same grip strength in their vagina as they did before, and where they feel they're more loose. And that can be due to the lack of, or due to the decrease of collagen as we age and going through menopause and childbirth.
And along with that, some women also complain that they don't feel like their vagina is as sensitive as it once was. So they'll say, it used to be if I had any stimulation in the vagina, I'd get really turned on and really excited. And now it feels dead down there. I've actually heard many women use that phrase. And the best way to resensitize the vagina and also improve the tightness of the vagina is by building vaginal collagen. Because when the tube of the vagina is more sensitive and tight, as a female partner, you're going to feel better during penetration. And the male partner is going to feel like he is penetrating a tighter vagina, which feels good for him too. One of the best ways to build collagen in the vagina, believe it or not, is with microneedling and radiofrequency. So a lot of women have heard about microneedling for the face. It does wonders at tightening skin and building collagen. It does the exact same thing in the vagina. Tiny little microneedles will make injuries all around the vaginal canal, and radiofrequency energy is emitted from the tip of those needles to really stimulate the production of new collagen and elastin. Just like PRP, we usually recommend a series of microneedling treatments once a month over a series of about 3 months. And then it does take, again, an additional 3 months to really build the maximum amount of collagen in the vagina to give you that more sensitive and tighter feeling vagina.
And there's also a less invasive way of delivering the radiofrequency. You can just deliver radiofrequency topically without the microneedles, but it's a lot less effective, but can be used as a treatment option if patients are afraid of the needles.
Or if they've had one treatment, sometimes they feel like, it was a little too intense for me. We can change them over to just using radiofrequency energy, which just feels warm and does not create the little micro injuries like microneedling does.
And then one of the last boulders that I did not mention in the beginning, but I think should be mentioned, there are some psychosocial aspects as well that can be a boulder for patients. So no matter how much we fix things medically, things that can happen anatomically or hormonally, there are also some psychological issues that patients can hinder their sexual satisfaction with their partners. And that could be from, past abuse or past negative association with sex. So those are some things that I personally do not treat. And we do recommend our patients to seek a therapist for that. Because no matter how much we fix things anatomically, if your psychosocial relation to sex is negative, you need to seek treatment for that.
So we've talked today about a lot of the common things that get in the way of experiencing a maximum sexual satisfaction, but a good provider should be able to take the time to talk to you, find out what boulders are in your pathway, and help you remove them. Thanks so much for listening to today's episode. No information from this recording is intended as a diagnosis or treatment for any disease. If you are enjoying the show, please subscribe so you don't miss any of our exciting episodes. And we love to hear from our listeners and would be grateful for your positive review. We'll talk next time.